So this is the right eye of a patient that was done a month ago with an extremely floppy iris. I mean, like really super floppy. And we're going to do the left eye today. He had a previous peripheral iridotomy. I think you can see that up there. And they'd done some laser in that one area where you can see a little thinning. But otherwise, I mean, his iris looks just fine. So I expect that he'll have a very floppy iris in the eye that we're about to do as well. So our plan is to insert a toric IOL in this patient at 167 degrees. Just look a little down toward the center of the light if you can. Good. So there's the toric axis marker, and I'm going to just place those marks. Now, this patient is a male with a mid-dilating pupil, and he's on an alpha-1 blocker called Rapaflow, R-A-P-A-F-L-O-W, and we did his other eye a month ago. And one of the most floppy irises I've ever had the privilege and honor to operate on. So this one's going to be the same. I mean, you can just bet it, all you got on it. So we'll have to reach into our bag of tricks and treat it accordingly. So here comes intraocular lidocaine. It stings a little bit. And next comes viscoat. And here we're going to fill it. The whole anterior chamber will be filled with viscoat. And we'll get the pupil a little bigger with the viscoat. Now, that's not a lot bigger, but it's bigger. So then the next question is, well, is that big enough for the technique that you use? And, well, that depends on the technique you use and how comfortable you are with a pupil that size. So I'm not going to go and stretch that pupil. I could. And we'll get, if I do, it'll be a bit bigger. Not as big as a pupil that's not floppy would get, but it would get bigger. You know, there's some people say you can't stretch a floppy iris. Sure you can. Of course you can. But just not as much. Won't stretch as much. So let's see what happens. Let's get our rexus done here. And that rexus will be almost as large as this pupil when I'm done. And that pupil's probably 5.5 millimeters, so we'll wind up with a rexus that's a little under 5. So there's our rexus. And our next step is going to be hydrodissection. Now there's epinephrine in the infusion bottle. And I know some people use a number of concoctions to try and enlarge or keep the pupil dilated. And that's fine. I don't have anything against them. I just never, for me, found that they did much. But if they work for you, don't listen to me. Do what works for you. Okay, so this is viscodissection. And this is, again, a little more viscodilation. All right, so here's a couple of principles for you. And just get infusion capacity. Good here, good. One is stay away from the iris sphincter with your phaco tip, because you want to leave the viscoat there. So this is when you really want to stay in the middle of the eye. Think of the viscoat as an invisible pupil dilator. If the pupil starts to come down in any area, go back and inject some more of the viscoelastic. Now, why do I use viscoat? Because it's dispersive, meaning it stays where you put it. It's not easily aspirated. Here I'm just rotating the eye so I can see deeper, so the little light reflexes in the microscope aren't in my way. So now we're ready to go ahead and divide this lens. It's not a very firm, hard lens. The patient's in his 70s. Let's go to quadrant. So we'll go along, we'll probably aspirate most of the remaining lens here, but the cornea. As soon as you see that little dry spots on the cornea, that's when you want to go right ahead and wet them. So here we go. It's still dividing. Now, you can get a little nervous. You say, gee, oh gosh, I can't see the tip of my chopper. Well, that's why it's all blunt. So it's really a pretty harmless device. Be nice if we can get this lens all divided before the pupil gets too myotic. And again, if and when it does, I'll be putting more viscoat in. But we may not need to. Well, see that attraction there? Now that'll happen again. It didn't get to the phaco tip because I'm in the middle. But I'm going to be putting more viscoat in momentarily. Okay, so now we'll just pause and we'll go back with viscoat. So you can see the iris wants to prolapse near the side port incision. It certainly would want to come out of the primary incision. So now you got a lower IOP before you come out. Position 0, see the fluid leaking alongside the phaco tip? If I don't lower that IOP to essentially atmospheric pressure, 0 or close to it, that iris will come right out. But if I lower IOP like that, it'll stay right where we put it. So now I'm going to go back in, larger pupil with viscoat. Wet the cornea, please. So we'll get it back up to about where it was, where we started. Now, I don't have anything against iris retractors. They're fine. In fact, if his pupil stayed the size it was a minute ago, that's probably what I'd go to. Some people prefer rings, Malyugin or other rings, and fine with me. But the technique I'm showing you is the technique that I typically use. Okay, so back in with the phaco tip. Notice how I have IOP settings very high. That's really desirable, because maintaining the IOP at a high level. Now, some people will lower the flow rate, and that'll make the viscoat stay in position longer. What I've elected to do here is to just put in more viscoat, keep the tip occluded so I don't remove much of the viscoat. So move these little particles up in the corneal, not quite up in the dome. So we're just about done with the phaco here. All we got left is that epinucleus there. And now we're ready to go in and do INA. And just before we do the INA, I'm going to use a little more viscoat. Enlarge pupil a little bit more. Don't need it as large for INA, frankly, as I need it for the phaco. Nuclear particles are segments can be fairly large, and you got to bring them up and see them and all that stuff. All right, so here we go, 90-degree INA tip. Now, what do you want to take out first? Probably subincisional, because that's the most difficult stuff to see. I probably had a little viscoat occluding it there, that port, but I've aspirated it. Nice and still. Patient moving a little bit restless, so I just advised him to be still. Now I've got some epinucleus here to my right, but so what? That'll get aspirated with high vacuum. I'm going to move it into the center. In fact, that's probably more than epinucleus. Be still. I'm going to leave that there for now and just keep removing cortex. You can see how still it is. That's because it's stuck in the viscoat. The same thing that's holding the pupil together, or dilated. So I'm just going to move that little chunk around. Wet the cornea. That piece came, so I'm just going to take it. That was a piece of nucleus or epinucleus. As is that. We probably have pretty much all of the cortex out. Let's take a look. We use the spatula. Well, what do you know? Something hiding there. And that's epinucleus. Aspirate that. And what you do with your spatula is just put it into an iris crypt. Nice and still. Be still. Hand on his head. The patient just woke up, so the technician's got his hand on his head. I'm going to now speak to him, make sure he's awake before we continue. You awake?
Yeah.
Good. Stay awake and stay still. You're doing great. Okay, you can sweep the iris this way. There's nothing there. So all we got left is that fragment suspended in viscoat there. So now we'll go in and put some Provisc in the bag. Now that fragment's a little too big to come out just by visco expression. So what I'll do here is, after I put the IOL in, see, I'll keep the viscoelastic here, I'll put the IOL in, and then I'll go in with the phaco tip and take that piece. So IOL insertion will be next. Spatula. So I'm going to use a spatula to fixate. Nice and still now. Remind the patient that who might have dozed off again, who knows, to be still. And insert the IOL. Now you're thinking, toric IOL, how's he going to see where that goes? We'll figure that out in a minute, but we will see where it goes. Either we push the iris or tilt the head or do something to be able to see where it is. And the patient woke up again. So we'll now make sure we can reestablish communication. Are you awake?
Yeah.
Good. Spatula. I want you to stay awake and not move. You good? You all right? Okay, so what I'm seeing here is he's kind of flowing in and out of whatever. So what I'm going to do, I mean, I don't want to move, and there's no harm yet, but we're going to tape his head now because, you know, why risk him doing some big movement? So we'll now, and there was a nice movement there as I spoke. We're taping him now. Taping is really simple and quick. The techs and nurses have been trained to do it and do it well. By the way, this gives you a good view of the L-shaped headrest that he's in, so his head can't move too far away from me. We've now got his head taped, so he could still move some, but I can't move him very far, you know, I mean, not much. So, not enough to do damage. All right, so back we go. We've got an IOL in there. Time to take out that remaining lens fragment. Okay, nice and still. That may not help to tell him that, but it doesn't hurt. And we'll put the spatula in now because we don't need a chopper. And then we'll hold the iris back with the spatula and just touch the petal a little bit. Dink, dink. Keep your hand on his head. My technician's got a hand on the head. Now we'll just buzz this. Okay, so now we're ready to do INA and position the IOL. You see there's a little fragment there, but that we'll get that with INA.
Cortex.
Spatula. Okay, and we'll hold his head still. Nice and still, don't move, okay? Good. Spatula in. I'm going to remove both of these fragments now while we got our sights on them. Okay, so we're going to nudge the toric IOL to the side, slip underneath it, remove OVD from the behind it. Now we've got the IOL in the sac. We'll take a look. So where are the little marks? See them? Okay, where those marks are, that's where the haptic optic junction is. We'll rotate the IOL some. Take another look. Maybe I'll use this crypt right here. How's that? What, the cornea? Good, so you can see where that is right on. Now let's go look on this side. I'm going to rotate the eye toward me, sweep the iris toward me. Notice, not quite right on. So I want to go back to this side and move it just a few degrees more. Like so. Okay, let's take a look. Okay, it's above. It's not right on. It's above. This one should also be above. Yeah, and it is. It's either above or just slightly less than the other one, but I think, you know, that's pretty much as close as we need to get it. it's within 2 or 3 degrees of intended, and that's fine. I'll look one more time over here. This time I see it a little higher. Maybe I'll just back it down. You know, can you rotate an IOL backwards? Sure you can. Just go from one side to the other. Like that. And then you can rotate an IOL in reverse. I wouldn't want to do that across the whole eye. Now let's see where we are now. That's too far. Good. And good. Now I've got both of them above the little marks. That one's above the mark. That one's above the mark. Yeah, I'm happy with that. I like that position. Okay, so we'll remove the OVD from the anterior chamber. And now remember, don't just come out now, or the iris will come, you know, right along with you. There's that mark right there, the 3 little marks. They're right where I want them to be. Right where the tip of my spatula is. Probably a little harder for you folks to see than me, but right near the tip of my spatula. And now lower IOP by just going to position 0 and wiggle your instruments. And then come away slowly, slowly. Okay. And your iris stays where it's put. Now, don't make it prolapse when you do stromal hydration. Well, how do you do that? Instead of just a big squirt all of a sudden, a gentle little side-to-side squirt. Watch your chamber get a little bit deeper as you do that, and then do a little stromal hydration on each side, like so. Now I've got a moderate chamber. Now I've got a really deep chamber, but it won't stay yet because we still have some leakage here. Good. A little more side to side. So that's kind of like sequential stromal hydration. Okay? And we'll be here for a little bit. I want to make sure that he doesn't leak, because if he does, he'll easily prolapse his iris. He's got some nice extraocular motion for us here, but not so bad. Okay, so my chamber is now normal depth. I suspect that the side port is still leaking a little bit, so I'm just going to hydrate that a little bit more. Keep looking straight at one of the 3 lights. The more specific your instructions for them to look, the better the chance that they can do it. Saying look straight ahead, well, that's fine, but takes in a lot of area, you know. But if you say one of the 3 lights, because they see the little dots. All right, so that one's sealed, and let's see. So this one, as I suspected, still has a little tiny leak to it. So you can trust the stromal gods to swell up and close for you. You can wait a minute or 2 and watch it stop as IOP gets lower. That's basically what's happening here. IOP is still around 20. Leakage is now just a little bit of it. You see just a little tiny bit. Now I know, I mean, I've seen this so many times. That little pouting of a drop of fluid now and then, that's going to stop within seconds as we speak, almost always. In fact, it's now stopped. So I'm going to now go ahead and put in the vancomycin. And I'm going to do that right through this incision here. Little fragment. I'm going to get that little fragment. Syringe with BSS. It's probably inconsequential, but you saw it, and it floated over by the pupil. So what I want to do is just irrigate and let it flow out of the eye. I think it's gone now. No, is it? Let's see. Yeah. Yep, it's gone. So what I did was irrigate over there, and it came over here and then flew out. So now, but what did I do? I just rinsed out the vancomycin. So what am I going to do? I'm going to put some more in. I'm going to put another milligram of vancomycin in. You might say, oh, gee, could that be toxic? Nope. No. We give 2 milligrams to people who have blepharitis and stuff. He doesn't. We've done that many times. And the toxicity of vancomycin would be much more than that. You'd have to go much more than that to get it toxic from the dose. I've heard from some docs who had dilution errors and gave 10 times that amount and did get some corneal edema, but that's never happened to me. And we're careful with dilution. You use 2 nurses, by the way. That's how you do it. One to watch, one to also sign the bottle or whatever that the dilution was done correctly. So we're done. Lots of stuff here. Floppy iris and nice case.